Our last presentation for today is by Professor Immo. He's from the London School of Hygiene and Tropical Medicine, and he'll present results on a multi-country initiative to accelerate elimination by reducing cross-border importation of malaria.
Yeah, that's good.
Well, thank you very much, and particularly thank you for staying. So I'll be talking about a multi-country initiative to accelerate elimination by reducing cross-border importation of malaria, or otherwise also called the Elimination 8. And I will be talking briefly about the background, how Elimination 8 was formed, the implications of the heterogeneity of transmission that exists between the member countries, malaria importation and the need that brings for regional approaches, and then the E8 border posts and the evaluation of their impact. The E8 concept was born out of a commitment that was made by African head of states to eliminate malaria in 2007, and then in 2009 the ministers of health of 8 southern African countries shown on the map here committed to forming a regional partnership to take concrete steps towards achieving the goal of elimination. And the E8 is this partnership, which is designed to accelerate progress towards elimination, aiming to achieve zero transmission in the 4 so-called frontline countries by 2020, and in the second-line countries by 2030. So an ambitious goal, and you can see in green there, those are the 4 frontline countries, and in orange, the so-called second-line countries. And this was partly motivated by very large reductions in transmission and in case incidents in the frontline countries. This is the cumulative total for the frontline 4 countries over the 15 years from 2000 to 2015. Admittedly, some of this was driven by changes in diagnostic practices, but there were some real high decreases in all these countries over this period. As you can see, those reductions have somewhat leveled out, and if one extended this to 2017, there's regrettably an increase in cases in the region, but I won't be talking about that today. The malaria incidence in the SADC region is shown on this map here for 2016, and you can see that there's a marked difference between those 4 southern countries of Namibia, Botswana, Swaziland, and South Africa, and the 4 countries to the north and beyond, with incidence in many parts of even the endemic parts of the frontline countries being certainly below 10 cases per 1,000 and often only hovering around 1 case per 1,000, with much higher incidences further north. And at the same time, there's extensive migration across borders in the region. We don't know exact numbers, but in 2013, the International Organization for Migration recorded over 4 million documented crossings, and estimate that for every regular or documented crossing, there are at least 2 irregular crossings across the many porous borders, which, if that was the case, would mean that there are approximately 12 million border crossings per year. Some of those are people migrating for economic reasons, for work, and some of them are backwards and forwards travel across borders sometimes just from within the vicinity of the border, people traveling across these borders, but always from, or very often from higher to lower transmission countries. And that is depicted here. So a person from a high-risk country traveling from a high-risk country to a low-risk country, and they're presenting as an imported malaria case, if they become a case in the low-risk country. And it should be noted that in some of the so-called frontline countries, the majority, for some of the districts, the majority and sometimes the vast majority of cases are actually imported cases. But that can, of course, then lead to onward transmission by that infected imported case and lead to cases of non-travelers in the frontline, in the low transmission countries. So do we have evidence of this process that people living amongst migrants but who themselves don't travel, are they at higher risk as a result? Well, there's one study, not in the E8 area, but in a country where at least the island part, Bioko Island, also has the goal of malaria elimination, and where a study was conducted in 2013, doing a survey on a boat that moved daily between the island, which had intensive malaria control and relatively low prevalence of infection, to the mainland of Equatorial Guinea, where prevalence is high because there's poor malaria control. And you can see from this that going from the low transmission island to the mainland, amongst children, for example, there the prevalence in the travelers was 38%, whereas it was around twice as high for travelers going in the opposite direction. So there's a daily imbalance in export and import of parasites between the mainland and the island. But how does that affect people who don't travel? And this can be seen from the annual malaria indicator survey that was done, where people were asked about recent travel history, and on the horizontal axis here is plotted the proportion of people in different neighborhoods who have traveled, and on the vertical axis we have the prevalence of infection in the non-travelers, so excluding those who were traveled, just the non-travelers. And there's a direct relationship between living in a neighborhood where a high proportion of people are travelers and infection prevalence. And even after adjusting this for the confounders that are obviously quite likely to be present in this, we still see very high risk of living in areas with high numbers of travelers to areas with high transmission. And note that these are high odds ratios, much higher risks than you would have from not using a bed net or not living in a sprayed house. So that is evidence that importation matters not just to the travelers but to the non-travelers as well. So how can cross-border malaria importation be prevented? You can stop migration and build walls and make them pay for it. Pardon the maybe poor joke. But more seriously, we could reduce malaria in the source countries, or we could clear parasites in the mobile populations. So before the formation of E8, but in the E8 countries, there's a good example of the effect of reducing malaria in source countries. This is evidence from the the Bombo Spatial Development Initiative from 1999 to 2007, where a major intervention was undertaken in southern Mozambique consisting of IRS, with no interventions apart from monitoring in the neighboring two countries of Swaziland and South Africa. So a regional initiative at that early stage. And the effect of introducing IRS, I think this is fairly well known, these data, was a dramatic reduction in prevalence in cross-sectional surveys over the each year after introduction of IRS, prevalence reduced. And this wasn't just a climatic oscillation, because we can see here because of the stepped way this was introduced, that pre-intervention prevalence was still high. But that is obviously nothing to do with importation. What was, I should master the skill of pressing a button.
It's just funky. Just keep trying.
A sticky button.
Can you? Yeah.
It seems to have stopped.
It's got it.
There we are. So in the neighboring areas of Swaziland and KwaZulu-Natal and Mpumalanga in South Africa, where no new interventions were introduced, there was a dramatic reduction in incidence in all three of them, simply because of the, or concomitant with and as a result of the reduction in malaria transmission across the border in source countries of travelers. So the second approach is clearing malaria parasites in the mobile populations, and that's what the E8 Border Malaria Post project is about. Its rationale is to provide access to malaria diagnosis and treatment for mobile and migrant populations, and for residents in border districts who often, who may be residents in those areas, but often are at some of the time travelers across those borders. And thereby to reduce parasite importation from high to low transmission countries, but also to try and improve understanding of cross-border travel. And the border posts, there are three types of them: a static border post, a mobile border post, and then something which is just a surveillance unit. Around 40 of them, of which half are the static ones, and about a quarter each of the mobile and surveillance units. And this is a map of where they are positioned. They're along the borders which have high transmission countries on one side, like Angola here, and then much lower transmission on the Namibia side. And basically between frontline and second line countries, but also along the border between Mozambique and Zimbabwe, where there is quite a steep gradient in transmission.
2-minute warning.
Okay. Do I get extra time for pressing the button?
It won't give it you.
So the implementation, this is frustrating, is that this has been introduced over the past 6 months, and we've had about 110,000 persons tested, but only 2.2% of those were positive. The highest prevalence of 22% in southern Angola, very low prevalence in Botswana, of only one case per 2,500. The target is, when this is fully operational, to test about 660,000 tests per year. Local cases are investigated as they normally are, as per guidelines. So the yield of actually treating people who are crossing the borders is relatively low, and we might have to investigate strategies to increase this through better targeting by continually analyzing the incoming data to direct the field personnel to high-risk subpopulations, possibly to look at more sensitive diagnostics, and possibly by providing incentives to the contractors who do this to find positive individuals. There's an evaluation of this border post initiative being undertaken for its impact. And the objectives of that, I'll have to, well, there we are to see whether this increases access to diagnosis and treatment and has an impact on prevalence in travelers and also on knowledge and attitudes, and to find out more about cross-border travel patterns. And then importantly, does this result in a decrease in imported cases in the low prevalence countries? I won't go through this because these are simply the outcomes that are linked to those objectives, and is done in a quasi-experimental, non-randomized matched pair design where we compare intervention areas where there is a border post with a comparison area where there isn't a border post, and so a survey is done in each of those at baseline and then at end line, and through a difference in difference approach we want to see whether the changes in those outcomes are higher in the intervention areas compared to the control areas. These are the locations of the evaluation sites along those borders, so it's only a small number of the actual border posts that are involved, with control areas where there are no border posts as a comparison. I'll skip this. And in summary then, the malaria elimination efforts in low transmission countries, as we've seen from research from widespread, is that the high level of parasite importation from high endemicity neighboring countries will hamper the elimination efforts. And this can only be addressed by either reducing transmission in source countries or clearing parasites in large proportions of migrants, or both. And in E8 this challenge is addressed by implementing regional interventions in the high burden countries and by setting up these border posts along key boundaries. But the challenge is to clear parasites in sufficiently high proportions of migrants and border residents. Remember, we have about 12 million migrations, and we are only aiming at approximately 500,000 tests per year. And not all of them, of course, necessarily have to be tested. So that the screening of migrants and border residents will have to be better targeted for this to have a big impact, but we are evaluating this impact and adapting the strategy as we go along. Just very lastly, I'd like to thank the many people who've contributed to this, not just from the Elimination Aid Secretariat, but also from UCSF, the malaria control programs of the 8 countries involved, and the partner research organizations in those countries. This is an ongoing project, and we hope to have some results of this next year. Thank you.
Thank you.